A warm welcome to all our Physio TV viewers. We welcome you from Physio TV and the team of Sancheti Institute College of Physiotherapy. A very warm welcome. We today have the part 2 of the talk by Dr. Asha Menon on the effect of McKenzie on chronic low back pain. So we welcome Asha ma'am again to kind of enlighten us and take us through the journey of how MDT helps chronic low back pain. Over to you, ma'am. Thank you.
Now let's look at we all incorporate manual therapy or some clinician forces within our orthopedic physiotherapy when we are treating chronic pain patients. And you know that when you're doing a manual therapy or a clinician's force on the patient, this is basically a passive thing. So, and we know that doing anything passive on these patients only is going to counter and support that illness behavior or the fear, or that they need us and they are probably not going to cope well with the condition. But there's a difference with how we would use our hands on. We have a system of force progression whereby we are also here. We are incorporating the patient into making them an active participant. Also, we would get them to problem solve within the manual therapy techniques that we are using. We are also getting the patient to actively participate when we are using the manual therapy. We are also getting the patient to problem solve when and use that particular force or problem solve to a lower force when they go back home and they are treating them and treating themselves or doing the home exercise program. What is force progression? We might use static forces, which could be done by the patient, and it's an independent role that the patient has got to further decrease their symptoms. Occasionally, we might need to help them with getting them to problem solve or getting them to come to a position where they can use patient-generated forces and dynamic movements. So the patient is doing patient-generated forces, and just let me get the laser. So the patient might would do a patient-generated forces, whereby he looks at his symptoms, he knows he's getting better, he is problem solving here. Once again, if there is an increase in the symptoms, he finds out why it is based on the education that we have given him, and then he knows how to reduce it. So he's working very independently here, and once he has come to a plateau, then we would increase the pressure by giving patient overpressure. So the patient uses further pressure by himself. So this is once again a very independent method where the patient is not really dependent on the clinician for reduction of his symptoms. Once the patient has exhausted the patient overpressure, that is his pressure, and now he's not further, there is no reduction of the symptoms, and now we as a clinician needs to put our hands on the patient. That's when we would still use a clinician overpressure, whereby the patient is moving and we are just giving an overpressure there. And once again over here, we are not just telling him, okay, do another 10, do another 10. While we are doing the clinician overpressure, the patient is very actively involved, because the patient is very actively involved and telling us, directing us whether our pressure is adequate for him, or does he want more pressure, or does he want us to put our pressure on a higher level or at a lower level. Because manual therapy in McKenzie method is totally directed based on the directional preference and centralization. So the patient is guiding us through, he's playing a very active role in the clinician overpressure. Once we have got the patient with our overpressure reduced with the symptoms, or he's abolished with the symptoms, or he is centralized, then we would once again ask him, well, would you like to do another set? And it is getting the patient very actively involved rather than just paternalistically telling him, okay, let's do another 10 sessions and let's see, and that would be your home program. Once the patient has gone back with the clinician overpressure, he maintains that overpressure, he maintains that direction, and he goes back to doing that with the same overpressure in his home, and while he's treating himself, while he's doing his home program, if there is a slight up and down with the symptoms, he is taught how to problem solve and maybe go a step down and come back a step up all the time while he's at home, while he's doing the exercises, so that he comes back to us at a stage once where he's exhausted of his forces, he has got better and come back, and now he needs us to put a greater force on him, and that's where we go on to mobilization. Once again, there is an evaluation here which is very much patient oriented, where the patient plays an active role, and we are deciding whether the direction is the same. Has there been a change in the direction in terms of force alternative, or are we going to be doing the same force progression? We go on to, at every level there is going to be an evaluation, and if at this level where the patient has come back with a clinician overpressure, we find that we need to do a force progression, that is, a patient is now, as a result of the previous progression of force, he's no better, we would then go on to a force progression and do a mobilization, which is what a patient, which is totally dependent on the clinician now. So here the patient, yes, plays an active role, but it plays an active role in only reporting to us about the symptoms, in reporting to us whether he wants a greater force or he wants us to go with a lesser force. Further to which would be a manipulation. So even when we are doing manual therapy on the patient, it is not a passive, it is more of an active, with the patient playing a very important and an active role. And all this would be with a directional preference. So it's not as though I would do flexion with a patient and the patient goes back home doing extension. What is the direction of manual therapy that we do in the clinic? That is extension, that or that is the flexion, or whatever is the direction of movement that is done, is what the patient goes back doing at home. So would all the any of the MDT classifications, would the cognitive drivers affect all of the classifications? Yes, the beliefs, expectations, perceptions of illness, fear, all these could affect any of the classification. That could be derangement, dysfunction, postural syndrome, or even the other subgroup. But the MDT clinicians can address these cognitive drivers. The contextual drivers, yes, MDT clinicians can address some of these, but if there is some, like for example, an access to care or an attitude of the family, friends, employers, these things, or a cultural setting, these are some things that a clinician cannot address. So if they are, for example, into the, so this is the ICF model of WHO, and if you are into the part B, where you have poor attitude of employer, low or non-access to care, these would be, these contextual drivers, it would be difficult for us to handle, and this would need definitely a multidisciplinary approach. So that was the ICF model, and these are well represented in the World Health Organization's International Classification of Functioning, Disability and Health, which is called as the ICF model. And so let's look at some of the evidences that are there for MDT with this population of patients. So let's look at with something with severe sciatica. It's an RCT, and we know that severe pain can also be a barrier to pain and to recovery, and it could be a driver to pain and disability. So this is Albert 2012, MDT versus lower extremity exercises. What was seen is that post MDT versus the lower extremity exercises would be the exercises that we would do for lower extremity, which could be an SLR and things like that. And it has been seen that the MDT group had a very significantly superior results on most outcomes in global improvement, on sick leave, work status, root compression signs, and patient satisfaction. So let's look at evidences with non-centralizers. So we are looking here at patients who have been having neuropathic pain, and they have been non-centralizers, in the sense we have not been able to identify one movement or a directional preference or centralization which could be good, giving good outcomes to the patient. And that means that exercises have not been proved to be beneficial to the patient. And what was done was these patients were picked up, and research was done in conjunction with MDT clinician and pain physicians. Transforaminal epidural steroidal injections were given, followed by MDT, and it was seen that we can prevent surgery to a large number of patients. So TESI, transforaminal epidural steroidal injections, plus MDT, and following which, so these were the non-responder patients who could very well have gone in for surgery. And post an MDT surgery, post an MDT reassessment, what was seen is that 78% of patients could avoid surgery. And this is a very substantial population of candidates. And so this contributes very heavily that if there are patients who are really not responding, we could probably get them with injections, with MDT. We could probably give them a chance to have a normal life and full functions without going through spinal surgery. So positive effects to the McKenzie method have been seen in various research papers from 2005. And so from 2005 on somatization, 2006 on kinesiophobia, 2011 fear avoidance for activity, start back high risk was 2018, psychosocial distress 2011, Christensen 2009 on depression symptoms, and Al-Abaidi 2011 was for fear avoidance for work. It's very difficult to put up every paper, so I'll be just honing in on a few papers. But prior to 2005 also, we have seen that leg irritability, or there's been a faster return to work, etc., with patients following the MDT method of management. So let's look at Wernicke 2018. This is a start back subgroup where the 109 patients were seen, and this was a high risk patient. That is, all 109 patients were high risk. And we know that outcomes in these patients are not going to be really what we desire. And these patients went through an MDT assessment. It was seen that there was no directional preference in 35% of the patients. And that means 35% of these patients would need multidisciplinary treatment, etc. But 65% of the patients got a directional preference post MDT assessment. And so what does it tell us? In directional preference, we have said that it is rapid reversals. Yes, understood that the patient may take slightly longer than a patient who is not a high risk category for drivers of pain and disability, but yet compared to the other patients, they would really come out well very fast. And at discharge, what has been seen as significantly more improvement in functional status. And so it tells us that identifying a directional preference in these patients can give faster, significant outcomes in the functional status of the patient. Let's look at another study by Wernicke 2011. This was 602 patients, diverse practice settings, and the patients had low back pain plus or minus the low back pain symptoms. 50% of them had intermediate or high psychosocial distress at intake. And these patients were assessed and treated by MDT clinicians. So once again, this is a very high risk patient. And what was seen is that 75% of patients reported less distress and improved functional outcomes at discharge. And 81% of the cohort had low levels of psychosocial risk at discharge. This once again tells us that the McKenzie method of management in the chronic chronic low back pain patient is a very active method of treating patients. And yes, We do identify these various drivers of pain and disability, and we are able to handle them well within the management. So let's look at Al-Obedi 2011, which looks at 62 patients with chronic low back pain, which had a greater than 2 month history, and they had a low back pain or a butt or a thigh pain, and MDT intervention was done. So you see 12 visits was done in these patients. As we say, most patients using the MDT method, if we are able to identify directional preference in a patient, the patient responds very, very rapidly. And within 6 to 7 sessions, we are able to even identify that the patient is going to respond to the treatment or not. So it's very, very rapid. And but the patient here has taken 12 visits. So we know that these are very high risk patients that we have seen. The patients all demonstrated centralization. So they were classified as derangement. So although they had showed centralization and although they were classified as derangement, they took a little longer for in the intervention, and that is 12 visits. And what was seen was the various biobehavioral outcomes were seen. And it was seen that there was significantly at both the 5th and the 10th week mark, there were significant improvements in pain and physical performance of the patients. Let's look now at now 2019, the systemic review, where we are looking at MDT, the outcomes with psychosocial outcomes in the low back pain patients. And this review had 16 studies, and it is a whopping 4,005 patients. There were one or more psychosocial outcomes that was identified here, and the association was decreasing with fear avoidance in all the patients, and in psychosocial distress was decreasing, depression symptoms were increasing, and what is so important was that there was the pain and self-efficacy that was increasing. That is, a patient's confidence level was increasing, and we were able to handle or tackle these various pain and disability drivers that we have identified. And so let's look at, now we looked at these patients who may respond, but there could be some patients who are not going to respond really, where we are looking more in terms of a nociplastic pain, where there is a reorganization of neurons, where there's a processing of pain that is, there's no pathology as such within the spine. And what would be, we would classify within the McKenzie system, we would be classifying them into the other subgroup. And what is the prevalence that we have seen in the McKenzie method in this subgroup of patients who would have outcomes which are not so good, and who would definitely need multidisciplinary treatment? We have identified in May and Rosedale paper of 2019, about 2% of patients would be featuring into the chronic pain syndrome. So what does it tell us really? That, you know, majority of patients who fall into the chronic pain, who would be a chronic low back pain patient with or without leg pain, majority of the patients, if you're going to use the McKenzie method, you can handle them very well and get them quite rapidly to go back to countering the drivers that we have identified, and getting them back to functions, back to work, back to leisure activities, and bettering the outcomes that we as clinicians are always trying to excel in. And so the bottom line that I can say is passive, no, not at all. If you are really trying to do things for the patient and make him feel good, that's really not going to work, because that's only going to support that illness behavior that they have. Yes, what is needed is getting that patient to take the responsibility for himself, taking the responsibility to reduce their symptoms, taking the responsibility to counter the drivers, and accept the responsibility that yes, some of my pain could be or symptoms could be because I've been having it for a long time, and I need to really work on it in a very positive manner. Look at what's getting better rather than what still needs to be done, and that would help and get the patient take on more responsibilities to self-managing their symptoms and to also getting themselves empowered. And I think I find it very beneficial as being a provider for the McKenzie method, that the chronic low back pain patients are easy to counter because we are able to identify them and manage them very specifically in a very tailor-made manner for every patient, rather than one size fits all. So thank you so very much. And I think I would like to end my presentation here. I hope everybody is like this.
Hello, ma'am.
Hello.
It's indeed been a very enriching session for sure. I'm sure all our Physio TV viewers are really going to benefit from the session,
Thank you.
without doubt. Ma'am, I guess there's been a real paradigm shift ever since McKenzie concept has come into being, into kind of getting this active patient involvement, which was not there before. I mean, there used to be more passive therapies, and also the concept of having this assessment driven management. So that has been, I mean, till that time, we used to kind of have a cookie cutter policy where one thing fits all, and there used to be this set of flexion based exercises which used to be given for all patients who come to us with back pains. So this has really been the changing, I would say, the paradigm shift which came into physiotherapy once MDT and, Dr. McKenzie brought about this whole change in our thinking process. And I guess you being our Indian representative has made us very proud in the
Thank you.
international scene, all right, and also being involved in the credentialing exams. I mean, that really speaks a lot, ma'am, about your experience also in this field. So coming to this thing, I guess the whole talk has been very, very identifying even the barriers of recovery. I mean, how fear of movement is countered by not only the repeated movements, but also making the patient feel that, this is how the pain is, this is how the direction is. And one thing is very clear, I mean, which was a very practical advice, was also that it's not as if the back pain is not going to recur.
Yes.
There might be recurrences, because no matter how active or how careful a person is, or how he manages his lifestyle and other choices and exercises, there might be times when we overdo certain things, and it's going to come back. And
Yeah.
but then you have the tools with you, to know what is to be done. So that's again a very strong point, wherein you do not have these patients keeping on coming to you every time there's a small this thing. They know how to manage that pain, themselves.
Yes.
And only in case it's not manageable, they have to seek help of experts and therapists. Ma'am, one thing that I kind of thought was missed a little bit. I think there's also a treatment about the lateral shift corrections, right? I mean, they do
Yes.
play a role. We do
Yes.
see patients, even with chronic low back pain, having a little lateral shift sometimes. It
Yes.
happens more often in acute patients, but we do deal with a kind of group of patients who do have this lateral shift still prevalent in them. So,
Yes.
ma'am,
So
how do you usually go about with this?
So I didn't really specifically say about it because a lateral shift, if it's an acute mechanical lateral shift, the outcomes are very good. Okay, the outcomes, because the McKenzie came up in the forefront first for this, because outcomes to a lateral shift was very poor even after surgery. So if there's a lateral shift, we do not just look at a lateral shift. We look at a lateral shift, and what's important is we identify within our assessment, is that lateral shift relevant to his pain? He may be having a lateral shift, but is that lateral shift, we have got criteria to see, is it really causing that pain? If it is not causing that pain, we do nothing about it and we just go on ahead. Now, if it is causing the pain, then we have two aspects of it. Now, let's say you have a relevant lateral shift which is causing the pain. Then a shift is something which, once again, there is a lot of active patient involvement. because the patient reports the symptoms to us and during the treatment, but it's totally a clinician procedure. Because to correct that shift, we need to, that is the first time in the McKenzie method where a relevant lateral shift is identified, and to correct it where the clinician puts the hands on the patient first. Otherwise, it's always patient forces. So we would have to correct the shift, and the patient is reporting to us all the time. And there's also a feedback from the patient on how the shift is now getting better. And when he goes back home, there's involvement by the patient to reduce the shift, to also sit in a particular way. How do you get into a chair, get out of the chair, and how are you going to the posture correction? The posture correction would be very different in this patient, whether it's an ipsilateral shift or a contralateral shift. So the posture correction would be different with these patient depending upon which shift it is also. And also there is a patient involvement that would be there when the patient goes back home and when he comes back. Now, the thing about, if it is a chronic, let's say the patient has come to you in a chronic. Now, the definition of chronic differs from different clinicians. So over an average, some people say more than 6 weeks, some say 8 to 12 weeks. So if it is anytime, let's say 8 weeks and above also, if you're saying, then the response may not be very, very good. Yes, I have seen patients who have come to me chronic, a relevant shift, and they have come through beautifully. But we cannot say that. Sometimes the outcomes may not be very good.
Okay.
So that's how it would be. But once again, even with a shift, although it is a totally clinician procedure, there is a lot of patient involvement there. But you will identify a lot of drivers of pain and disability in these patients, because the patient realizes that he's got off center. Either it's a shift or a kyphotic deformity. So they have not been sleeping.
Okay.
They could come with not sleeping for 15 days.
Oh my. Okay.
So we have got to counter all that and get them to self-manage and empower them. But that happens eventually, and they come back.
So, ma'am, does the frequency of the patients coming to MDT, I mean, for the MDT, for example, I know it's more patient driven, and we kind of play an active role only when the patient is not able to self correct. But, ma'am, in a chronic low back pain, what has been your experience about how frequently do you need to kind of handle the patients? And how do you kind of give them the program and, send them home for doing the things on their own at home? And how often do you call them? Yeah.
So it is, if you are going to see, it could vary very much. So let's say you have a patient who you have examined today and you have not been able to, there's a lot of fear, a lot of pain, and also lots of drivers positive there, a lot of failed treatments, this also get that anger out of them, and emotions out. So if you have a patient where you've not been able to really get a very conclusive thing on day one, and we've got equivocal responses, I might just send the patient off with a posture. And I might then tell them that, look, this is a test exercise I'm giving you. And I want you to do this so often. It takes you about a minute to perform. And all that I want you to do is do it several times in a day. And I would not tell them to do it several times in a day. I would say, how often do you have 1 minute for yourself? And they would say, oh, 1 minute I can have many times. You tell me. And okay, fine. So how often can you find? Okay, I can do it as many times as you can, or 3-4 times. All right, fine. So can you add another 3-4 times? All right, can you do it multiple times in a day whenever you remember? Come back to me in 48 hours. And this will be a report that I'll get from your body. Just like you do an MRI, you get a report. This will give me a report about you, and then we will take it up from there. So it gives me an opportunity to get the patient empowered, to get the patient also to come back and reevaluate that patient. And also, sometimes, I might not have got anything definitive within that repeated test, but I've got something where the posture correction has got the patient better. So, and I'm going with something that might probably give me a result, or it might also tell me which direction I need to move the patient in. So I could do that and then call the patient in 48 hours and reevaluate. Or on a general, I would get the patient to come back in a week's time and then 10 days and 15 days. But if the patient needs a little bit more education, I might call them a little bit in between. Can you come back in 4 days' time? But generally on an average, about a week. About a week is that I would need.
Okay, thanks, ma'am. I'm sure the readers or the listeners would have much more queries to this, and we will be forwarding the questions to you. And I hope you can and I will kind of pass on the answers to the
Sure.
groups. So that's one thing for sure. And
So
one thing
this,
that
Sona, what happens is it leaves me, I've called this patient after 1 week. So it leaves my time free for those who actually need me. Na?
exactly. In
This
fact,
patient,
that's exactly. So in fact, it kind of I believe a lot in empowering the patient because there needs to be. In fact, in India, I think the need is more
yes,
because there's a lot of emphasis as well as I would say the patients also tend to kind of get into this rut of relying on the passive therapies. They are like, nahi,
yes,
mujhe, ye machine de do, give me this modality and I'm going to get better. It's just like they want a quick fix for everything and they
yes,
don't really want to take the responsibility of getting themselves better. Where again, we have to counsel them, very often, I guess, as MDT therapists, you all would need that to be done a lot in India, where you have to counsel the patient to have this paradigm shift even in his thinking process, where you kind of tell him, look, I know what your pain is, and this is something that you have to do to get yourself better.
yes. And
So,
so, but once the patient realizes that, I think
exactly,
they come, and
exactly,
all that we need to do is when there's multiple treatments which is not
exactly,
helped out,
exactly,
multiple treatment failure, there is a lot of pain and driver. So we need to just tell them that, look, you've done all this, isn't it? So do you
yes,
want me to do the same thing? It's not worked for you. Can we do things a different way?
yes,
Rather than telling them that let's do things different way, can we do things in a different way? What do you think?
exactly.
Yes, let's give it a try. That's what they say.
Yes. Okay, ma'am. Thanks a lot. Thanks a lot for
Thank you
this
so much.
opportunity, and uh, for the all the listeners of Physio TV to have I'm sure they're going to benefit a lot from this talk, and I'm sure you're going to have more queries for your MDT course, which is going to come
Anytime,
soon. And ma'am, we look forward to other talks with you on Physio TV. In fact,
anytime.
this talk has been so nicely even peppered with a lot of evidence from literature, which is even more significant. In fact, if you see some of the articles which ma'am has quoted had not only more than 600 patients. There was one study with, which had compiled everything with more than 4,005 patients. It was like a meta-analysis. And to see that the patients have, evidence is pointing towards McKenzie working or the MDT working itself should give all the clinicians out there also a direction about how they should go about, and also to kind of learn about MTT, come and kind of learn about it, know how to use it for your spinal patients, and I'm sure it'll work wonders. So
Thank
thank you
you.
so much, ma'am. Thanks
Thank
from
you.
the entire team of Physio TV as well as Sancheti Institute of Physiotherapy.
My
We,
pleasure always.
yes, ma'am. We also would like to thank our chairman, Dr. Parag Sancheti, and our executive director, Manisha ma'am, and as well as our IT team, Mr. Tushar, for helping us with this recording as well as presentation of this physiotherapy talk. So thank you, ma'am.
Thank
And
you
as
so
we
much.
wind up, yes, thanks
Yes.
a lot.
Bye.
Thank you,
Bye.
ma'am.